So we'll be starting. Dr. Uzair, are you ready?
Yes, sir.
Okay, can you speak up while you present because your voice is a little low? Um, so I
Sure,
welcome
sir.
you all. So I welcome you all to yet another session of the Resonance module, Resonance Corner. These sessions are arranged by Department of Neurosurgery at Liaquat National Hospital. The idea behind these sessions are so that we can build a 3D neuroanatomy, which is very important while doing any neurosurgical procedure. Uh, we are honored by two expert panelists today. Our first guest panelist is Professor Chandrashekar Deopujari. He is a senior neurosurgeon from Mumbai. He served as head of department and professor of neurosurgery at Bombay Institute of Medical Sciences, along with affiliation with several other institutes in India. He currently serves as chairman of WFNS Neuroendoscopy Committee. Um, his interests are minimally invasive surgery, pediatric surgery, epilepsy surgery, vascular disorder surgery, and gamma knife radial surgery. He has extensive. He has his enjoys an outstanding publication record and as an editorial board of World Neurosurgery, Child Nervous System, Journal of Pediatric Neurosciences, and Minimally Invasive Neurosurgery. He also holds esteemed posts in various professional organizations and neurosurgical societies in India. Thank you, sir, for your presence. We are honored. Our second expert panelist, I think, who will join shortly, is Dr. Azam Ahmed. Dr. Ahmed is an associate professor of neurological surgery and radiology at Wisconsin, and he is trained in cerebrovascular surgery, endovascular, and skull-based neurosurgery. He is medical director at University of Wisconsin for the Comprehensive Brain Tumor Program, and also looks is the director and is also a director for multidisciplinary pituitary clinic. We also are honored by Dr. Azam's presence. Dr. Uzair, can you please start with your presentation?
Sure, sir. Assalamu alaikum and good morning, everyone. I'm Dr. Uzair, resident neurosurgery, going to present a brief overview of anatomy of the lateral ventricle. The detailed explanation we have already studied around a month ago. Today, our main topic will be clinical presentation and operative approaches for the lateral ventricle pathologies. I will just give a brief overview. So starting with the anatomy of the lateral ventricle, we all know the brain and the ventricular system arises from three primary brain vesicles, giving rise to five secondary brain vesicles. Then they gives to the adult derivatives. So the vesicular cavity becomes a ventricular system, and the uh, area around them form the cortical structure. So at the end, this ventricular cavity is enclosed within the deep cerebral matter, like we experience in the adult brain. So these are the primary brain vesicles, secondary brain vesicles, and these are the parts of the adult brain that contain the cavity within it. These are the lateral ventricles in the cerebral hemispheres. Thalamus has the third ventricle, midbrain has cerebral aqueduct, pons and cerebellum have fourth ventricle as their part of ventricular system. So this is a normal routine diagram that we experience in almost all of the neuroanatomy books. This is a lateral view of our brain and the ventricular system. This is anteroposterior view. We can appreciate that there are two C-shaped structures in each cerebral hemisphere that are interconnecting through a midline, a small structure that is the third ventricle that in turn connects with a cavity of the midbrain that is cerebral aqueduct that connects with the rhomboid fossa or the cavity of the cerebellum and pons as fourth ventricle. So
Um, Dr. Uzair, you are. I think you went mute. Can you unmute yourself again? Imad, can you make him the host again? I think, uh, Dr. Uzair, please unmute yourself.
He's already a co-host. He has to unmute himself. Yeah.
How much I have this?
Just one slide, I guess. You can continue with the present slide, please.
Sure, sir. So these are the parts of the lateral ventricle. We can appreciate this is a C-shaped structures, different color donation. We can appreciate this red midline structure is septum pellucidum. This yellow egg-shaped structure is actually thalamus, and this tadpole-like structure is fornix formation. So we can appreciate there is a frontal horn, there is a occipital horn, there is temporal horn, and there is a dilated portion known as the atrium. And the structures that are in close proximity with the ventricular system are um, thalamus, septum pellucidum, deep cerebral white matter, corpus callosum, caudate nucleus, and fornix. We will study its relation with the lateral ventricle one by one, but briefly. So here again, this is thalamus. We can appreciate it is forming some part of the floor of the frontal horn of the lateral ventricle, some part of the anterior wall of the atrium of the lateral ventricle, and some part of the roof of the temporal horn of lateral ventricle. Here we can also appreciate this red structure that is actually a midline structure. Beyond it would be a lateral ventricle of the opposite side. It is midline and separating both lateral ventricles from each other. And there is the fornix formation. We can appreciate the mammillary bodies. It's column of the fornix, crura of the fornix, and then fimbria of the fornix. I tried to explain the fornix formation schematically in order to understand a better relationship. Here we can appreciate the mammillary bodies. These are the column of the fornix going in proximity at the level of foramen of Monro. That is an important landmark during endoscopic surgery. And the kiss fornix of the opposite side, and then they begin to deviate from the opposite infero laterally, and these are the commissure of the fornix, and they communicate with the fimbria of hippocampus, and this is the hippocampus. So this is superior inferior view. We can appreciate these are the mammillary bodies, these are the fornix, and they come in close contact with that of the opposite side at the level of the foramen of Monro, and then begin infero laterally and join the fimbria of the hippocampus. We can also appreciate thalamus yellow colored on the right side, forming different structures and relationship with the lateral ventricle, forming some part, forming base of some part, roof of some part, and anterior wall of the some part. And then again, here is anterior-posterior view. Here we can appreciate the relationship of the lateral ventricle and how fornix is closely associated with the structure. And we can appreciate this septum pellucidum mentioned in red color. And another important structure that is in close contact with the ventricular system is corpus callosum. We all know that corpus callosum is type of association fiber that connects the cerebral hemisphere, which of the opposite side. The anterior inferior-most portion is rostrum, and the posterior inferior-most portion is splenium. And between these, we have the genu and we have the body of the corpus callosum. Having a brief overview of corpus callosum itself, we know these are the association type of fibers that communicate one cerebral hemisphere to the other. We can appreciate in the midline, there is no problem in communicating with the other hemisphere as it's giving fibers directly. But in order to communicate the frontal horn, these fibers have to make a loop around. So this loop or band of fibers in front is known as forceps minor, where is in occipital lobe, there are two bands of fibers. So this is forceps major, and laterally we have tapetum. Here we can also appreciate the relationship of corpus callosum and internal capsule. We can appreciate this is anterior limb of the internal capsule. This is the posterior limb of the internal capsule. And lateral to it, we will have lentiform nucleus found by the putamen laterally and globus pallidus medially. Beyond that, we will have a thin layer that is known as the external capsule. Then we have a thin layer of gray matter known as the claustrum. And then we have extreme capsule, and very lateral to it, we will have our insula. So in this diagram, the red structure shown in relation to this light shaded, blue shaded ventricular system is actually corpus callosum and its fibers. So this is the frontal horn. Here is the genu of the corpus callosum, we will have rostrum somewhere here, and these are the projection fibers, the hair-like structures. Then we will have splenium. So these are the corpus callosum fibers. The another structure that we can appreciate here is the caudate nucleus. It is shaped like we can say a rat with its tail around. Here is the head of the caudate nucleus. Then we have the body of the caudate nucleus. Then we have tail that is in close contact with the amygdaloid nucleus. So this is our basal ganglia in situ. Now putting it all together, we can appreciate this light shaded blue structure is our lateral ventricle. This purple structure is thalamus, and this orange structure is caudate nucleus. We can appreciate its head here. Here we have the body of the caudate nucleus, and then we have the tail of the caudate nucleus. Here we can also appreciate internal capsule. This is the anterior limb, and this is the posterior limb. And these are the green structures known as the lentiform nucleus. So putting it all together in infero superior view, we can appreciate these structures. These are the fornix. We can appreciate they are going superiorly at the level of the foramen Monroe, and then they begin to move outwards inferiorly. And here we have the frontal horn of the lateral ventricle. Then we have this occipital horn, and here we have the temporal horn. We can appreciate its close relationship with the fornix, and we can also appreciate its close relationship with the caudate nucleus and its body and tail. Here we can also appreciate lateral ventricle close proximity to the corpus callosum and their association fibers. We can appreciate these medial fibers are actually forceps major, and these lateral fibers are actually tapetum. And this is another view, anteroposterior. We can appreciate these two lateral ventricles coming in contact with each other. Midline, there would be a septum pellucidum. These red fibers are actually corpus callosums, and this would be the tapetum. And there is a caudate nucleus. We can appreciate that head of the caudate nucleus is in close proximity with the frontal horn of the lateral ventricles.
I'm sorry, Dr. Zaid, but your pointer isn't moving. So can you please make sure that, yeah, we can see it now, but previously when you were explaining, it wasn't moving. So, you know.
So there is another schematic diagram showing different relationship of different structures with our lateral ventricular system. We will have a cut section, vertical cut section one by one in order to understand it better. Here is a cut section at the level of the frontal horn, limits its anterior to foramen of Monroe, and anteriorly we have pharyngeal columns. Roof is formed by the corpus callosum. Lateral wall is formed by the head of the caudate nucleus, and inferiorly we have the rostrum of the corpus callosum. Then having another cut section at the level of body of the corpus callosum, we can appreciate at the level of body of the lateral ventricle, we can appreciate the roof is entirely formed by corpus callosum. Medially, we have septum pellucidum. Caudate has acquired a more lateral position here, and the thalamus is forming the floor of the body of the lateral ventricle. And here would be a sulcus, striothalamic sulcus that houses the thalamocyte vein that is an important landmark during endoscopic and open surgeries. And moving forward, we have another cut section at the level of atrium. We can appreciate laterally it is formed by the tapetum. Medially, we have forceps major, and two important structures are calcar avis and the collateral trigone. Basically, these are not structures, these are the indentation of the calcarine sulcus into the atrium and indentation of the collateral sulcus into the atrium. So these are the calcar avis and the collateral trigone. So occipital horn, there is no as such vertical section available, but we can appreciate from these diagrams that the roof, some part of the roof is formed by the tapetum, lateral wall is also formed by the tapetum, and medial wall is formed by the forceps major and the calcar avis. And the floor is formed by the collateral trigone. Then we have the temporal horn. We can appreciate tapetum remains at the lateral position. We have some part of the tail of the caudate nucleus here. Thalamus is at the medial position. We have the fimbria of the hippocampus, and the floor is found by the collateral eminence and the hippocampus. So this is a brief overview in order to understand the anatomy of the lateral ventricle. In this MRI section, we can appreciate different structures. These are the frontal horn. Here in the midline, we have septum pellucidum. Then we have the head of the caudate nucleus. We have internal capsule, making this obtuse angle. This is anterior limb of the internal capsule, and this is the posterior limb of the internal capsule. Lateral to it, we have lentiform nucleus that is found by the putamen externally and globus pallidus externus and internus medially. Then lateral to this lentiform nucleus, we have external capsule, then we have claustrum, and then we have extreme capsule, and lateral to it, we have insula. So, and this giant structure here is thalamus, between which we can appreciate a slit-like third ventricle. So this is another schematic diagram like the MRI I just showed. This orange structure is caudate nucleus head. This is frontal horn. This is lentiform nucleus. The dark green is putamen and the light green is globus pallidus. We have external capsule, claustrum, and extreme capsule. Then we have insula later on. This purple structure is thalamus, and its midline structure showing septum pellucidum. Then this is a coronal section showing relationship of the ventricular system. We have this corpus callosum fibers. These are the head of caudate. Then we have lentiform nucleus, and so on. These are the structures already I have explained. Now, coming to the cadaveric section, we can appreciate this is interhemispheric transcallosal approach. This area is relatively devoid of the cortical veins, so it is an relatively safe passage to enter the lateral ventricle through interhemispheric approach. We can appreciate different structures here. This rounded structures or the hole in the roof of the lateral ventricle is actually foramen of Monro, through which this lateral ventricle is communicating with the third ventricle. This is the septum pellucidum. We can appreciate some indentation of caudate head into the frontal horn. And this is the anterior caudal vein. Here we can appreciate the thalamo-striate vein that is in between a sulcus between thalamus and the caudate nucleus. Here we can also appreciate the choroidal fissure. And these are the body of the fornix. These are the different structures. And this is another insert magnified view of ventricular system, cadaveric dissection. We can appreciate caudate nucleus indentation in the frontal horn, thalamus indentation, and these are the body of the fornix moving laterally from each other, going all the way down. And here we can also appreciate laterally how close this ventricular system to the lateral most insular part. This is another insert of the diagram I showed earlier. This is the foramen of Monro. We can appreciate the column of fornix here. This is the thalamo-striate vein between the indentation of thalamus and the caudate anteriorly. Here we have the choroidal fissure that enhouses the medial posterior choroidal artery and the choroid plexus. We can appreciate the choroid plexus of the lateral ventricles are going in continuity into the third ventricle through the foramen of Monro.
Dr. Zair, I'm sorry, but are you using your cursor while explaining? Because we can't see it. The participants.
Yes, sir, I'm using it.
But I think it's not moving on the screen. Can you just make sure that it moves?
Can you see it right now? Because
yeah,
I'm using
it moves,
it to explain.
Are you moving? It's not moving right now.
I'm still moving it.
Yeah,
I have
it
been
moves,
moving
but
it all the time. Maybe some connectivity issues or.
Can you use a pointer, Imad? Can you help him?
Pointer has been disabled because of certain reasons.
Also, the volume is a little low. If you can speak a little louder or take your speaker, please speak.
I'm using microphone and it's just in contact with my lips.
Okay.
I've tried to speak a little louder, sir.
This is much better.
Yeah, this is better, but can you please try and use a pointer while explaining, because the participants, are missing the points.
Sir, annotator has been disabled, so I will have to use pointer cursor of my laptop.
Okay, let's just try that, that they can identify the
So I will
structures.
move it a little slower. So if it's due to connectivity issue, it gets stuck to a particular structure. So this is a ventricular system. If we remove all the cerebral cortex from above, we can appreciate this ventricular system. Anteriorly, here where caudate nucleus is written, is the frontal most part of the lateral ventricle, that is frontal horn of the lateral ventricle. Then if we come backwards, we can appreciate foramen of Monro, through which these lateral ventricles are going to communicate with the third ventricle. Here another structure is labeled, that is genu of the internal capsule. We can appreciate anterior limb and we can appreciate posterior limb. Then coming backward, we can appreciate the choroidal fissure, and coming backwards, we can appreciate this dilated most portion is atrium of the lateral ventricle. We can appreciate indentation of calcarine sulcus as calcar abyss into the atrium. We can appreciate indentation of collateral sulcus as collateral trigone, and we can appreciate this atrium is now connected with inferolateral position temporal horn. So this is the lateral ventricle structure if we remove all the cerebral cortex and view from above downwards. Now this is another view showing different important structures. We can appreciate foramen of Monro on each side. We can appreciate thalamostriate vein on each side. This is the indentation of thalamus. These are the superior choroidal veins. And for the last slide, we have this brief overview of the arterial supply of ventricular system. We have anterior choroidal artery, that is a direct branch from internal carotid, as it just bifurcates into MCA and ACA. And then we have lateral and medial posterior choroidal artery. So this is just a brief overview, because arterial and venous drainage itself is a very detailed topic, and we have already gone through it in our last presentation. So that's all regarding the brief overview of ventricular system. And if you want to have a look at the detailed discussion on the same topic, you can also go to our channel Neurosurgery LNH and type in the link. You will find a detailed presentation. Thank you, sir.
Thank you, Dr. Uzair, for your presentation. I would like now for Professor Chandrashekar to add his expert opinions and maybe share a case if that is possible.
I can share some cases and we can make the relevant points at that time.
That will be nicer.
So basically, I think today we are talking of lateral ventricular tumors. Well, we are talking of anatomy of lateral ventricles, but obviously it is most important for the tumors in this area. What is also important is some of this anatomy which is centered around foramen of Monro and the floor of the ventricle is equally important in one of the most important procedures we have learned in the last 2 decades. That is the third ventriculostomy, which is becoming prime sort of treatment for many cases of hydrocephalus. And in terms of intraventricular tumors, I think what has happened is that over a period of time, how we treat them has really evolved. And I'm just going to share 2 or 3 cases with you just to show how this has evolved and how does this anatomical knowledge help you to avoid problems and facilitate better excision. Can you see my screen?
Yes, sir. Your screen is audible. Yes, we can see your screen.
So one of the most important things to remember is that if you know the age of the patient and the area involved by the tumor, the pathology of these lesions is such that most of the times you can actually make a reasonably correct diagnosis. As you can see that foramen of Monro is one of the most common areas where you see tumors, and most of these tumors are either subependymal giant cell astrocytomas, pilocytic astrocytomas, and if you look at the trigone, you would predominantly find a meningioma and the choroid plexus papilloma, depending on the age of the patient. Of course, you want to have the complete excision of the tumor and cure from the tumor, but it is challenging because of the difficulty in accessing these areas. As you must have seen, they are all bound by the important structures as have been just described. And other important things are the location of the vascular pedicles in this area. We have seen that the confluence of the veins occur near the foramen of Monro. We have seen that the basal ganglia are protruding into this, and if the tumors are either attached to any of these structures, it can have a devastating kind of effect. So microsurgical strategies also look at the point that are you entering the ventricle through the cortex subcortical area, or you are entering it from the corpus callosum, which is the other approach. And of course, endoscope gives you, it's a transcortical approach, but gives you another kind of perspective. So this is a typical case. You mainly find this in the middle age group, and this is a tumor which is involving both the lateral ventricle, the body of the ventricles, and you can see that it has gone in both the ventricles. It is probably centered around the septum. And what are we really trying to do in this case, and what would be the best approach? I would like to ask Dr. Farooqi to probably let's make this a little interactive.
So the participant can use the chat box if that's okay with you, and I'll convey the answers.
Okay, they are not directly available.
No, sir, no.
For some reason, the chat box is not available to me. Okay.
You
So
can ask the question. You can just ask the question.
Okay.
Yes, sir,
ask the question on the chat box.
No, you can ask the question and they will answer on the chat box. You can just ask the question.
Perfect. So, transcallosal approach is the answer given by Dr. Pravat Singh, I think.
Yes, sir.
And transventricular approach, of course, but which way do you approach the ventricle and where do you want to attack this tumor first is the question. What I would like to say to the person who has described transcallosal approach is always look at a coronal picture to understand what you are trying to do. When you have a lesion coming up to the top of the ventricular system in the lateral ventricles, it is not so easy to approach it through corpus callosum because that angle is not available to you for vision directly. So this is the coronal picture. Any change in idea now?
Will you still go transcallosal, or will there be a change in your approach?
So basically, transcallosal approach will not allow you to get to the left side where the tumor is almost having a parenchymal encroachment or has certainly touched the top of the lateral ventricle. And as the tumor is almost, touching the parenchyma, we feel that it may be a better approach. So that is my way of looking at it. It gives me a better perspective of the tumor, and as you can see that the tumor going on to the opposite side is definitely under the corpus callosum, and I may be able to get there if I enter through there. So that is one part of the issue. What is the tumor most likely to be? At this age, the most likely to be tumor is probably a benign tumor like a neurocytoma, which are locally malignant, of course, or ependymoma. And therefore, we are looking at radical excision, because if you're looking at a frankly malignant tumor, you may consider mainly restoration of CSF circulation and a biopsy as your primary aim of the surgery. So in this kind of a patient, we think that we should be able to radically excise, and therefore we have to choose an approach accordingly. So we do a frontal craniotomy on the left side. I'm doing a transcortical kind of approach by doing a small topectomy, and you can see that the tumor is visible to you right over there. Navigation certainly helps you, and these tumors have fine kind of a capillary blood supply which is being gradually, and you can see that this can be done virtually without using a retractor once you have got a good access, and a dynamic retraction can be done. We have been able to decompress, and once you have done that, once we have gone through the tumor, I have not included all the areas, but you can see with the endoscope later on that you can see right up to the trigone at the back. You can see into the area where the tumor was attached to the septum, and we have gone onto the opposite side. And one of the most important advantages of using an endoscope is also to make sure that you have achieved a proper hemostasis. And we plug this with a sort of roll of gel foam, and you can see that we have been able to achieve a complete excision in this patient. And this was a neurocytoma, which is a benign tumor. This surgery is done about 7 years ago, and thereafter there has been no further issues. One of the most important things to understand why the retractor should not be used is that just opposite foramen of Monro, as you have seen in the anatomy lecture, you have the genu of the internal capsule, which can be very easily injured if your retractor, if you try to retract too vigorously into the lateral ventricle at the level of the foramen of Monro. I would go on to the next case, and the importance of vascular pedicle. This is most important for choroid plexus papilloma and also for meningioma. The most common location for these meningiomas is, of course, at the trigone. And this is a diagrammatic representation. And you can see this tumor, which has presented predominantly with headaches. Fortunately, there is not too much hydrocephalus at this time. And if such a patient is asymptomatic, you can probably wait. But this patient had severe headache, was a lawyer, and insisted that if it is possible to get it operated. What are the problems when we are dealing with a left trigonal tumor? Entry into the ventricle in this kind of a corridor is through the parieto-occipital sulcus, classically described. And you can get the left hemisphere problems, especially the syndromes which are associated with higher functions. And therefore, it is important that you find your line of attack very properly. And this is the position which we use for this kind of a case, a shunt-like position. But more importantly, should be your angle. And this angle can get you through more eloquent cortex. This angle probably saves you from that. But my personal preference over the years has become this sulcus, which is just the last sulcus before the occipital lobe starts. And the main reason for that is you are likely to avoid all the complications associated with this. And the second advantage is that you can get to the vascular pedicle, which is always posteromedial, coming from the posterior choroidal artery. So this is how you would approach this tumor. Early control of feeding vessel is desirable. I also sometimes use ultrasound to select my trajectory if I do not have a navigation available, but usually navigation is used. You will enter the ventricle with a needle and then follow it to reach there. And you can start seeing that we have reached the pedicle, and I have already started coagulating the pedicle in this patient. Once you can satisfactorily coagulate the pedicle, the tumor is becoming You can see that it is the blood supply is once the blood supply is sort of cut off, it is much easier to debulk the tumor without causing too much bleeding, and the tumor is mobilizing so well that you could virtually remove this after coagulating the choroid plexus also just around it. So the trajectory is important. Taking the feeding vessel initially is important, and that is how you get the whole tumor out. And this lawyer could go back to his practice in about 3 weeks' time. And this is the post-operative MRI, which we typically do at about 3 months' time. What about endoscopic resection? I think colloid cyst has become quite popular indication, and of course, most of the cystic lesion. But for solid intraventricular brain tumors, it still has certain limitations. The main limitations are how do you gut the tumor? Endoscopic CUSAs are becoming, cavitrons are becoming available for that. And I'll just show you one case. We recently acquired this. This is a 18-year-old female. You can see that there is a hydrocephalus. She's presented with subtle signs of gait deterioration, and you cannot exactly locate the tumor till you look at the fact that the foramen of Monro is almost virtually blocked bilaterally, and the tumor is located here in the septum, going partially into the frontal horn. You can see that there is not much in terms of enhancement. So relatively avascular tumor, it is situated here near the foramen of Monro. So location as well as the low vascularity makes it amenable to endoscopic kind of a, and this is where we have entered through the frontal burr, and you can start seeing the tumor straight away. You can see the choroid plexus just underneath it. So we first take a biopsy. And once the biopsy is taken, we introduce this cavitron, which is can be passed through the side channel. And the most important thing is it guts the tumor at a very low intensity. There are two kinds of cavitrons available for endoscope. One is the end cutting and one is the side cutting. People feel that they are important in different ways, but you can see that as the tumor is getting gutted, you can see the shrinkage, and you can see that we can remove more and more tumor as it goes till we find a proper interface, and we have been able to get virtually a complete excision, detaching the tumor from choroid plexus in that area. This is the post-operative scan, which shows a complete excision, and this turned out to be a subependymoma, which is one of the classical kind of tumor which is amenable to this kind of a resection. So these are the two CUSAs available. One is I think the American brand is called Nico Myriad, and the German CUSA is becoming more popular now, which is made by a company called Zuring. This paper actually describes, though it is an old paper, it describes very nicely what are the indications today for neuroendoscopic kind of treatment of intraventricular lesions. It certainly is the best way to establish a diagnosis and achieve a good CSF circulation. And this can be followed by definitive surgical treatment if the lesion is not directly amenable for endoscopic excision. And gross total removal of intraventricular tumor is becoming more and more possible with aids like ultrasonic CUSA, endoscopic CUSA. So I think the ideal tumor for endoscopic resection should be low vascularity, soft consistency, relatively small. Associated hydrocephalus helps a lot in getting into the ventricle without causing much of a problem. And therefore, colloid cyst, subependymal giant cell astrocytoma, low-grade gliomas, occasional central neurocytoma, which is small in caliber, can be good. I have used it also for choroid plexus, mainly to coagulate the pedicle before I go for proper surgery. And sometimes if you coagulate the pedicle, the tumor just comes out very easily. And a purely intraventricular craniopharyngioma is also becoming an indication over a period of years. I would like to end my presentation by sharing this case with you, which is a unique case which I have recently treated at the Children's Hospital. This patient has a choroid plexus tumor near the foramen of Monro, and this child is only 2 months old, presenting with hydrocephalus. When we saw this, under the age of 2 years, there is a high suspicion that it can be a choroid plexus carcinoma. So as I told you, age plays a major role in sort of making our diagnosis. So we thought we should attempt to take at least a biopsy, put a reservoir, and then come back to decide what we are going to do. The biopsy showed this to be a non-malignant choroid plexus tumor, and therefore my colleague decided at the same time that we should probably shunt this patient. And shunting was done at this stage. What was most surprising is that after shunting was done, this child developed an ascites. Such a severe ascites that he needed tapping at least virtually alternate day, and more than 200 cc's of fluid was being removed. So choroid plexus tumors can sometimes cause excessive secretions and the shunt may not work. And therefore, we went ahead and excised this lesion. This is the smallest choroid plexus, smallest in the sense, youngest patient I have treated for a choroid plexus papilloma, where I had to remove this tumor at the age of 4 months. And fortunately, the child has done well. So I just thought I'll share some of the highlights, the role of endoscopy, and most importantly, choosing a proper corridor is extremely important apart from just the technology to avoid complications. Thank you.
Thank you, Professor Deopujari, for presenting your cases and with excellent outcome. And you highlighted some very important points about the corridors. If there are any questions from Professor Deopujari, we're happy to take it. You can write your questions in the chat box. So the first case that you showed where the tumor was involving the cortex, if there was no hydrocephalus, would you still have taken a transcortical approach if there wasn't hydrocephalus?
So I think as that tumor had just transgressed the ependyma, I think it was safe for me. I knew where to enter it directly into the tumor, and therefore I was unlikely to be disturbed by the smallness of the ventricle. Therefore, it would have been possible. But if I have a tumor, especially something like a colloid cyst, where the ventricles are not dilated at all, I still prefer transcallosal approach. But it is becoming less and less common that I would use a transcallosal approach. I have gone through 3 phases. I started off with transcortical approach as I learned during my early training period. Changed over completely to transcallosal approach for about 10 years in 90s. And from 2000 onwards, I have again come back to transcortical approach because most of the surgeries are endoscopic or endoscope assisted.
Thank you, sir. If there are any other questions from the participant, we'll be happy to take it now. We have Professor Deopujari. I think since we have no questions, sir, I thank you again for your presence. It was an excellent presentation. We would like to have you in the future as well. And thank you, sir.
Thank you very much.
Thank you.
We have our friend that joined us? Or?
No, sir. He sent his regrets. I think he had a busy day yesterday, and he said, okay, please pass on my regrets to you as well.
Oh, so I'm sorry. I was looking forward to sharing some. Okay.
So he'll be present. He'll be present in the next week. He'll be present there next week. If you are interested, we can have you on as well.
Is that on what, third ventricle or what is the
third ventricle?
Maybe I'll join you next week.
Yeah. Okay. Thank you, sir. We'll remind you of it. Thank you, sir. Thank you for presence. We'd like to end the session now.
Thank you.
Thank you, sir.